Good afternoon, everyone. This is Justin Rush from NASTAD. I just wanted to say formally thank you so much for your time today. We're looking very forward to having this conversation with you around anti-stigma advocacy and HIV prevention and care, lessons from the Black Lives Matter and Queer Dreamers movement. It's building on the Practicing Cultural Responsiveness webinar that we had last month. So with that said, I know we have a lot of information to relay, and we definitely want to save time at the end for questions, comments, and concerns. Just a little bit of housekeeping. If you would like to unmute your line, you can press *7. To mute it, you press *6, and that'll come in handy towards the end of the webinar when we go through our question and answer. And with that said, I'm going to go ahead and get things started. So like I said, this is Anti-Stigma Advocacy and HIV Prevention and Care, Lessons from the Black Lives Matter and Queer Dreamers movement. So just to do a little bit of an overview of the webinar, we're going to first talk about addressing stigma and revisiting its importance. We're going to talk a little bit about Black Lives Matter's work at NASTAD, our perspective in the working credo, and the future technical assistance that we're going to be providing in regards to Black Lives Matter. We're going to discuss what quote-unquote radical TA could look like, which includes engaging communities, strategic partnerships, and building movements. We're going to have a conversation from our speaker, which is Jonathan Lights from the Black Youth Project 100, and have a conversation about the work that they're doing. We're going to discuss addressing stigma at the systems level with state partnerships. My coworker, Edwin Corbin Gutierrez, is going to be handling that. And then we're going to have a question and answer section. So with that said, at the bottom of the screen, you should be able to see a chat box. If you have any questions throughout the chat, please be sure to pose those questions, and we're going to be getting towards those questions at the end of the webinar. And if everyone can hear me, can I just get you all to write, "We can hear you" in the chat box? Well, raise your hand. I just want to make sure that okay, got it. Everyone can hear me. Great. Thanks so much. All right. So just to do a little bit of talking about Black Lives Matter from the perspective of what NASTAD has been doing and our credo and work and moving forward in regards to technical assistance. Back when our previous executive director, Julie Schofield, before she left, she really sat down with all of us as staff and had a conversation around the Black Lives Matter movement as it was going on in our country around the prison industrial complex in regards to police brutality. And she really got us thinking about, what does Black Lives Matter mean in the realm of public health? What does it mean to assert that Black Lives Matter in regards to public health? So over the course of the past few months, we've had an entire Black Lives Matter team, which consisted of Mariam Baba, Joe Caldwell, Blake Rowley, Amora Amoyge, Edwin Corbin Gutierrez. A number of different people at the staff level have been trying to figure out what NASTAD's position in response to a lot of the Black Lives Matter work that's going on currently in our country and how we can tag into that work. So this is just a little bit of a statement in regards to where we are so far, and I put working in the parentheses because this is something that is in flux. This is something that we're going to be working on and officially releasing a little bit later. But it's just all about getting down to the heart of social justice and making sure that we're doing what we can as a chief representative for health departments to help mobilize state and territorial HIV prevention programs, to help health department staff create multi-sectoral partnerships, so working with faith-based communities, working with Panhellenic councils and national Panhellenic councils and Black Greek letter organizations, and getting to the heart of social justice, and not just talking about the social determinants of health from a 30,000-foot perspective, but really getting deep and down into advocacy and health departments seeing themselves as advocates moving forward. That's the type of work that we're going to be engaging in to try to assert that Black lives, yes, do matter in the realm of public health. Just to give a little bit of an idea as to what social justice in action can look like, and I have some of our rock star members and states and jurisdictions. If I've left you out of this, please charge it to my head and not my heart. And also, when thinking about formatting for stuff like this, it's kind of hard to put an entire list of 25 states, I guess, but really getting involved with your community. That's what social justice in action looks like. getting to the heart of meaningful community engagement. We see bridging the gap between faith-based and MSM communities. Virginia is a jurisdiction that is doing a really great job of this. They've been hosting a convening of faith-based leaders with MSM and faith-based leaders and health department staff to work through the stigma that can potentially arise within religious settings. So that's an amazing example of what that can look like in social justice in action, working with advocates to educate policymakers. I know a lot of work has gone on from the health department level in regards to the Georgia Sexual Health Policy Symposium, which just occurred this past week in Georgia, which is an opportunity to bring in advocates, experts, health department staff, and legislators to come up with equitable outcomes in the state of Georgia. So shout out to Devin Barrington Ward in regards to that effort and the health department staff, actively working to undo racism. So our member, Deanne Gruber in Louisiana, has the Undoing Racism team come in, and if you haven't really heard about it, they come in and they do a number of trainings, and they talk about privilege, they talk about institutionalized racism, and she's had a number of her staff, a large part of her staff, to take part in that effort, working with communities to ensure marginalized populations know their rights. So that's very important, specifically in regards to HIV criminalization. So some people may not be knowledgeable of what their HIV status and what disclosure might mean within their state. So working with individuals in your state to make them knowledgeable of their rights, and then opportunities to educate and collaborate with the community. So MSM symposiums, Georgia, New Jersey, Virginia, Tennessee, South Carolina, North Carolina, and I'm sure a number of different places are having MSM symposiums. So it's an opportunity to educate the community, but also collaborate in the future, build strategic partnerships, and really just not view the community as someone that you're just servicing, but is getting to the heart of community-based advocacy. So if you're providing a service for an individual, it's also great to have their input on what their advocacy needs are, and then as well work with them to work towards those advocacy goals. And in the future, and we're talking about social justice technical assistance, we love our continuum. So this is just an example. My coworker and colleague, Kelsey Donaldson, who works on the health systems integration team here, we've been working on figuring out what a technical assistance cycle or technical assistance continuum could potentially look like. So all across the board, we know that we have a number of jurisdictions some that are contemplating, some that are preparing, acting, and maintaining their social justice action. So this is just an opportunity to see what that could look like. So we have some key indicators, and we have a couple of examples on how you can engage these jurisdictions, what planning looks like across that continuum or across that life cycle, lots of peer-to-peer technical assistance opportunities that could potentially arise with some jurisdictions that are really social justice action-oriented, with some who are not so much. But it's really all of these slides are just an opportunity for us to state that moving forward, social justice technical assistance, just like technical assistance for communications or prevention or treatment as prevention or around any myriad issues that individuals come to NASTAD for. As the chief representative for health departments within jurisdictions, we want to make sure that if you need assistance with creating collaborative partnerships or getting to the heart of meaningful community engagement and social justice technical assistance, then we can assist you with that. So with that said, I'm going to introduce our speaker for today. His name is Jonathan Likes, and he's going to be discussing lessons from the civil rights movement. Just a little bit of background information around Jonathan. Jonathan Likes is committed to educational equality, human rights, and increased opportunities for all students and people regardless of their socioeconomic backgrounds. In 2011, Likes spent 6 months in South Africa working in Cape Town with a grassroots movement called Equal Education, where he joined to help organize students, parents, principals, and NGOs and the government to progress towards a better, more equal education system. Jonathan graduated with his bachelor's in political science and recently completed his master's in social service administration and policy, and he also completed his thesis and a documentary project which examined the marginalization of queer communities of color. So with that said, I would like for you all to I would like to introduce Jonathan Likes. Jonathan, if you would like to unmute your phone, go ahead and press *7 and let me know when you would like for me to go slide to slide, and we can go from there.
Okay, fantastic. Can you hear me, Justin?
Yes, sir, I can.
Okay, great. Welcome, everyone. I'm glad and honored to be on the call and be able to share some insights that I've had over the past couple years within the Black Lives Matter movement, what's now being called the new civil rights movement. So I kind of hold two positions. I'm the policy analyst at the Center for the Study of Social Policy, really trying to think at large about systemic racism and how we're shifting systems to better meet the needs of children and families that are marginalized across the country. Then I'm the co-chair of Black Youth Project 100, and we'll get much more into BYP 100 as the presentation goes on. So you can go to the first slide, Justin. So this first slide is really to just kind of give more context about the movement for Black Lives, also known as the Black Lives Movement. Often folks think it is just one organization that's kind of leading this, and that couldn't be anything further from the truth. The Black Lives Matter movement is probably 50 to 75 different organizations around the country, really trying to come together and build institutional power with each other to fight for freedom and justice for all Black people. And it's been centered around the criminalization of Black communities, but it's absolutely more than that. Folks are really wanting to move the conversation into economic justice. We're talking about health disparities. We're talking about equality in education systems. So this is not about pieces of the experience of Blackness in this country. This is about us being able to address the whole experience of Black people and how we can fight for freedom and justice in that context. So I've listed a few of the organizations that you might have already heard of. So Black Youth Project 100, we have 6 chapters around the country. The Black Lives Matter movement has about 26 chapters around the country. And then there are groups that started in Ferguson, that's Organization of Black Struggle or Ferguson Action Network, but also groups like Ohio Student Association has also done a lot of civil disobedient work in trying to really put their bodies on the line to confront the state in the last year. So you'll see more and more organizations, thinking of organizations in Cleveland and Minneapolis now. A lot of folks around the country are coming together to really push the Black Lives Matter movement. So it's absolutely not going anywhere. There's a lot of plans for 2016. Back in July was the first opportunity for all of these groups to come together and meet in the same place and try to share a cumulative agenda that folks can work on. So that was a great opportunity. Next slide, Justin. So this is just the mission and vision for the group that I work with, Black Youth Project 100, a group that actually was started by a Black queer feminist. She's also the first Black lesbian to lead the political science department at University of Chicago, Kathy J. Cohen. She started the Black Youth Project a while back out of a research project trying to gauge the attitudes and perspectives of Black youth around the country when it comes to their political engagement. But Kathy Cohen back in 2013 brought together 100 Black youth activists from around the country, and it just so happened that that weekend that she brought us together was the same weekend that the Zimmerman verdict was released. So imagine being in a room with 100 Black radical young folks from around the country, and immediately folks wanted to make a decision to really try to form an exclusively Black organization where folks can come together and try to build economic, social, political, and educational freedom when it comes to young Black people. So we notice that there's a lot of programs for high school age youth, and then a lot of programs once younger Black folks kind of reach their professionalism and careers and such after 35, but there wasn't any kind of critical mass or center of gravity around the country trying to organize young Black people between the ages of 18 and 35 in this country, and that's exactly what Black Youth Project is trying to do, and they're trying to do that through building a network focused on transformative leadership development, nonviolent direct action organizing, advocacy, and education. Next slide, Justin. So this is, this is one of the simplest slides that I have, but it's so important when it comes to how we approach meaningful community engagement. We absolutely believe that the first thing, I mean, if we're trying to engage communities, you have to build authentic relationships with people on the ground. There's no way to get around that. There's no easy way to kind of move in that space. You have to be on the ground talking to people that you're either building policies about, that you're trying to build agendas on, kind of this framework of I work out of D.C. and I work for a public policy think tank, but my think tank also believes that you can't really create policies without talking and looking into the eyes of the people who those policies are impacting. And that's the same thing that kind of is existing more and more within the Black Lives Matter movement. Folks are building relationships on the ground, and they're doing that through this experience, values, and action continuum, really trying to understand that experiences shape people's values. And you have to learn about someone's experiences first, and then that will lead you to understand their values. Once you understand someone's values, that is the only way to move them to action. So a lot of times we're thinking, well, a lot of young black gay men might not be taking their medication for several reasons. And when we're thinking of issues like that, often people move to either stigmatize or not really try to understand from a strengths-based perspective how these people are experiencing their lives on the ground on the day-to-day. So this framework of like really trying to drill down and take the time to understand people's experiences and values first, and then understanding that the only way to move people to act on anything is to go through that framework, and that's kind of how we understand it in the movement as we're building relationships on the grounds with people. Next slide. So the other thing that's critical to Black Youth Project 100, and I'm seeing this framework, I'm happy to see this framework more and more in different movement spaces around the country, but we do our work through something called a Black queer feminist lens. And to us, like, we have to ask ourselves the question, who are we centering? Who is in the center of the conversation as we do all of the work that we do? Next slide, Justin. So this next slide really starts to articulate what the Black queer feminist lens is, and we start off with who we call Mother Audre Lorde in the movement, referencing a lot of her work and a lot of her literature, but we start off with her quote, "There's no such thing as a single issue struggle because we don't live single issue lives." And this is so important when thinking through a public health lens, because you can't just think of someone through a public health lens. As you're thinking about about holistic health and healing of individuals across the country, you also have to think of what other issues does a person bring to the table as they're bringing their health struggles to the table. What other identities do people bring to the table as we're also trying to address health disparities around the country? So we really try to use this Black queer feminist lens to understand that people's identities make them vulnerable to multiple types of oppression. We also want to understand that, particularly through the Black queer feminist lens that BYP works in, we understand that liberation for all Black people can only be realized by lifting up the voices and experiences of historically silenced and vulnerable groups within the Black community. So this means to us, I mean, an example of this within the Black Lives Matter movement is you will often see the name of cis hetero straight men lifted up within movements, especially when it comes to overcriminalization of Black communities. So you'll hear the names of Trayvon Martin, you'll hear the names of Mike Brown, and you'll continually hear the names of men, and that silences and makes invisible the experiences of a lot of trans trans women that have a lot of issues when it comes to criminalization and over-policing and profiling. That makes invisible the issues of black cis women who also have a lot of interactions with police and the police state, and queer people at large. So BYP is committed to centering the experiences of those groups who don't often get talked about when we think about the criminalization of black communities. So that's so important to us. Right now in DC we're doing a campaign against the school-to-prison pipeline. So we're trying to say, okay, within the school-to-prison pipeline, who's talking about the young trans woman who might have tried to use the restroom that fits her identity, but might have been suspended for that. And we know, like in schools around the country these days, when young people are suspended, there's also a pipeline. There's literally police officers within the school that are often connecting these young people into the prison industrial complex. So we have to think of not only the consequences, but the lens in which we're tackling these issues. So if we're thinking about public health, how do we not only think about the full and holistic health of individuals that we're either trying to treat, or large public health issues that we're trying to confront, but how do we recognize the humanity of bodies that have been made inferior throughout history? How do we recognize that history and lift up the humanity of those vulnerable groups? Because we can't have yet another movement that is going to lift up only certain populations and then leave others behind. We can't have a public health movement that's going to lift up certain populations and leave other populations behind. So this next slide is really about power, privilege, and intersectionality, and it poses two questions within health departments. One, how are we risking our privilege in shifting power? And two, how are we using an intersectional lens towards HIV prevention? There's nothing we can do when it comes to social justice issues, when it comes to fighting for equity and trying to create justice, if we're not thinking about the privileges that we hold. This idea of intersectionality comes from Kimberly Crenshaw, who is now leading the Social Inclusion Institute that comes out of Columbia University. But intersectionality is about how are we recognizing the multiple modalities of oppression that impacts people's lives simultaneously. So if we're not thinking about the multiple privileges that we hold and also the multiple oppressions that individuals that we're serving have to navigate, then we're doing an injustice to the work. If we're not prioritizing issues of power, who holds power? How is power distributed within organizations and within communities? Who's at the table? Who's talking? Who's getting to decide how these health initiatives are implemented in communities? There's a infamous quote said across many systems, nothing about us without us. And this is about incorporating the voices of people on the ground into everything we do within health departments and through this public health lens. So this is really to say, one, check your privilege, check the power that we hold as we're going into extremely vulnerable and marginalized communities, and really try to understand the perspective of how those communities need to be able to come to the table, not with pieces of their identity, but with their whole selves. And we need to be thinking about shifting power into the hands of those communities. Another thing I often talk about as we're creating interventions to a lot of these, the issues that we face in our society, oftentimes we're sitting in boardrooms and sitting in offices where folks have a lot of educational privileges. We often forget to think about the interventions that folks have created for their own lives already. So I do a lot of work within the child welfare system, which connects a lot with LGBTQ homeless youth. So as we're thinking through that perspective, what are the interventions that young LGBTQ and queer homeless youth have created for themselves? Where are they going to survive? So we often, right now we're doing a whole initiative with the ballroom scene, really trying to lift up how young people create interventions for themselves, how they create solutions to their own problems. So before we come in and say, hey, here's a 5-point plan of the solutions we think you need to implement into your own life, we need to start that conversation with what interventions and solutions have you created for your own lives, and how can we help and support those things as we bring you resources and try to shift power and try to understand how privilege operates in our society. Next slide, Justin. So this slide, I apologize for it being overwhelming, but I just wanted to point out how the Black Lives Matter movement, how the movement for Black Lives is understanding kind of this idea of radical inclusivity within Black spaces. And this goes back to working through a Black queer feminist lens and really trying to center the populations who have experienced the most vulnerability in our society. But I want to point out just a few things within this. I'm not going to go through each point. I want to point out a few things here, though. One is this idea around the politics of respectability. It says, Black Youth Project does not advocate respectability politics, meaning we do not look to the middle class for examples for how Black people should dress or act. This is a huge problem when it comes to doing work with marginalized communities. Often people feel stigmatized. People feel like people often try to judge them or tell them, look, if you act this way or dress this way, or if you pronounce your words in a particular perspective, in a particular way, then you will achieve better outcomes. Then you will achieve access into spaces, and that's just not true. We understand that how marginalization and oppression works in our society. It's not about the individual acts that people make. It really is about systems of oppression and really a history of oppressive policies that have been embedded into systems throughout our country, and those are really span wide when it comes to the history of health policies. I mean, people's mistrust of even the healthcare system. I was reading an article today looking at how they were, and this could even go back to the Tuskegee Institute, the testing that they did then. I was reading a new article about how folks and how they, in World War II, they were testing nuclear weapons on Black soldiers. That history within marginalized communities isn't just erased. We have to recognize where the roots of this mistrust is. And then having this kind of respectability politics only reinforces that marginalization and really causes us to lose a generation of people that really need to be connected into systems of care and into these movements that are kind of trying to fight and push for equality for all people, centering Black people into that conversation. So yeah, just to talk about what are the things, what are the tangible things that health departments or people working within the healthcare field can do. The first suggestion is get proximate. It is our distance from an issue that allows our society to think that things are just when there's no justice in sight. We have to get close to the issue and to the people that are experiencing these hyper-marginalization levels. If you are talking about HIV prevention and have not been on the ground to talk to the people, the day-to-day people who are experiencing this issue, then you're doing this work a disservice. We have to be proximate, we have to be close to the issue, and we have to be speaking every day to the people who are experiencing these issues on the ground. We have to be intersectional. We have to allow people to bring their whole selves to the table. We have to understand that we have very complex identities all the time. And folks have gotten to a place where we are no longer willing to bring parts of our identities and then leave others behind. We just would rather not come at all. So we really have to be thinking, what are the multiple complex identities that people are experiencing, and how do those identities either make it easier or more difficult for people to reach justice and to reach equality and to reach optimal levels of health care care and of happiness in their lives. So if we're telling someone, hey, you need to take this PrEP pill, but we're not also trying to identify their housing needs and their kind of like 101 day-to-day needs of eating, of food, things like that. Honestly, we really have to, it's not rocket science in a lot of ways, but sometimes we're asking people to do these things that would help their lives, but then forgetting some of the things we take advantage of in our lives that those folks might also need. The third one is leading with strengths. It's very important to, and this kind of comes out of Social Work 101. I'm sure there are many social workers kind of on the webinar, but this is just coming with a strengths-based perspective, not marginalizing folks, understanding that stigma, especially within the field of HIV, is still running rapid, and folks are experiencing this in their communities, in their families, but also in the public narrative overall. So we have to be strengths-based. Find out what people's strengths are, and then build on that. The fourth one is it's very important to shift the narrative that young people are experiencing when it comes to marginalization within the healthcare system, when it comes to the Black Lives Matter movement, when it comes to economic justice and folks' rights to equal and comprehensive education. We have to change the narrative to be one that doesn't work from a deficit frame, but a narrative that leads on the strengths of people, a narrative that that is accessible to folks, and a narrative that doesn't stereotype people and reinforce this kind of oppression lens in people's lives. So I think anytime we're hearing kind of these stereotypes from people, or anytime we're seeing policies around criminalization impacting people who are HIV positive, we need to change that narrative and fight against those narratives and provide new frames to understand the healthy, positive, loving, beautiful lives that people are living out. The fifth one is really trying to understand and work through this anti-oppression framework. And this is really understanding how our systems, both the policies built into systems and the practices built into system, how is that either furthering oppression in people's lives or undoing that oppression in people's lives? And that really goes back to understanding issues of power and privilege, but that goes back to us looking at the details of our agencies. How are healthcare agencies working with communities not to further marginalize them, but to undo, first of all, understand that oppression, the history of oppression in these communities, and then to undo and fight against that oppression? And then this last one is really kind of this policy and action agenda, what that means for Black Youth Project 100. We've created two policy agenda. One was called the Agenda to Keep Us Safe, which came out January 2014, which was really an agenda tackling the specifics around the criminalization laws that are perpetuating the criminalization and over-policing of Black communities around the country. Next month, Black Youth Project will come out with an economic policy agenda trying to address all of the ways, really calling out, we kind of fantasize this idea of Martin Luther King and forget about the radical king that was really trying to organize sanitation workers and build a poor people's movement. So this next policy agenda will be trying to call out what is the radical economic justice policies that we need to be pushing all around the country. But there's also a lot of potential for these policy and action agendas that are really trying to push some of the on-the-ground community organizing happening around the country. So we would love to work with folks. We're thinking about doing a policy and action agenda around healthcare disparities or around equality in the education system. So those are possible and potential partnerships that can happen in the future if folks are interested in plugging in and connecting into this movement happening around the country. And then the last slide is my information. Please, if you have any further questions, I'm happy to answer them on the call, but here's my information at the Center for the Study of Social Policy. I'm more than happy to talk about these ideas and share this perspective with anyone that is interested. Thanks so much for having me, and I'm looking forward to hearing your questions.
Great. Thank you so much, Jonathan. We definitely want to thank you so much for your attendance on today's webinar. And I think, like I said, we're going to save some of the questions until the end. I think we're going to have just enough time. But I think that what you were just talking about is a perfect segue into what my coworker, Edwin Corbin Gutierrez, is going to be talking about, which is alleviating stigma at the systems level and what those interventions can be. So with that said, I'm going to pass it over to Edwin Corbin Gutierrez.
Hi, everyone. For the last part of the webinar, we are going to look a little bit more into how stigma operates and then tie that into system-level interventions that we can do to address some of the attacks on identity and build strengths-based interventions, as Jonathan was just talking about, to change the narrative at every step within every part of the structures and strategies that healthcare and public health organizations follow. And I'm hoping that part of that will be adding to the policy agenda initiatives that bridge a sense of health outcomes with performance indicators. So I think the first kind of construct that I want to get at in this conversation around stigma and how it operates is that stigma is not just part of the furniture. It's not part of the waiting area, and it as much as it is ingrained in the everyday work of many clinics, health departments, and just part of the delivery of care. It is also it's not natural. It's propped up. It takes a lot of work to replicate and continue to make effective these stigmatizing actions and language. And so we want to take a step back and look at who is performing these stigmatizing functions, what they count on, what assumptions they're going on, they're following, and by looking at that kind of internal logic, then we can start to piece it apart and make it a little more vulnerable. An example here is a provider refusing care, and as we face this reality, there are many different ways to address it. Today, we're going to talk about systems level change, which could include trainings. It could include guidance on the job with specific recommendations around language and professional responsibility, which we will get to. And we will have a webinar coming up in early 2016 addressing these specific measures. But we want to understand the structural responses that we can have, establishing best practices, involving our data systems, the metrics that we use to measure performance, and again, tie those performance outcomes to health equity. These are, again, we're going to continue to talk about these examples of what several surveys have found. These quotes are coming from a study that Lambda Legal did in the experiences of LGBTQ folks and LGBTQ people of color in healthcare settings. And we want to be able to identify trends and find opportunities for intervention. This is the model that we're using here at NASTAD to understand how stigma operates. Stigma is an attack on the victim's identity, and it relies on being able to break that identity and sense of personhood in order to a stigmatizing message is able to vilify, abuse, mistreat, objectify someone's sense of personhood and identity through these attacks. And key in this process is the way that these attacks go unchallenged by authorities, by peers, by the system. And it's also incredibly important for the stigmatizing process to reinforce itself. So in the example that we just read on the previous slide, the provider blames the patient, and which makes it okay to mistreat the patient, and then that in turn allows for treatment to be rough, or for outcomes to not be accountable. And when it is not challenged, it is reinforced, and it becomes the norm. And that's how it is perceived as just part of the furniture, part of the protocol, part of what we do every day. So it really depends on champions to be able to identify those instances where stigmatizing message, behavior, language is happening, and be able to address it, call it out, and kind of piece it out of the rest of the procedures, the clinical best practices that are happening. Oftentimes it is just embedded in our everyday life. We are working on, this is a rough draft of our model, but we are working on figuring out how stigma operates and the different tactics that we can use to unhinge it and make sure that people can see it, that advocates have tools to be able to piece it out. We can use humor, we can teach best practices. The first piece is really to acknowledge it and understand the values, like Jonathan was talking about, that are driving people both to make those assumptions and stigmatizing messages, as well as the values that we depend on to be able to decouple that those behaviors from best practices at the clinics and public health settings. And then there's a piece around urgency that we really need to address, and that's why the temperature check is so important. And again, this goes back to something that's become really crucial for us as a society given this new civil rights movement. A lot of these stigmatizing messages are embedded in our everyday life. And so we have to ask ourselves, given the disparities we're facing, given the disparities that key populations are facing, Black and Latino MSM, transgender women, are we conscious? Have we ourselves internalized a lot of these disparities? Are we willing to tolerate them? Shifting gears a little bit, I want to talk a little bit about our work here at NASTAD. The framework that I just presented is developing out of almost 4 years in examining stigma in public health settings. We conducted a national survey with health departments, providers, clinics. We held a national panel of expert providers and stakeholders, and created 2 optimal care checklists, which provide guidance on best practices to address the sexual health needs of Black and Latino gay men and other men who have sex with men. We did a national summit on the elimination of public health stigma, and we have two optimal care checklists. The previous one was for clients, and this one is for providers. Both addressing the same issues from 2 different perspectives, and providing some language, some resources, and references to best practices around sexual health. And then we also developed and published a stigma toolkit. called Addressing Stigma, a blueprint for improving the HIV care continuum for Black and Latino gay men, which offers 17 recommendations to reduce stigma. And it's been downloaded or accessed over 25,000 times in the 12 months following its publication. Looking at some of the structural findings, there needs to be a renewed focus on advocacy, particularly around HIV criminalization, prosecutions, and arrests. And Justin talked a little bit about this at our previous webinar. The importance of HIV related measures to ensure that immigrants, regardless of immigration status, are able to access prevention and care services. And then there's a number of LGBTQ health equity policies that are also that have been in place or are being proposed that it is important for us to support, and we'll talk about those in just a second. In this work, we've identified a series of cross-cutting components and issues that we want to make sure we continue to address, and we want to. I think some of the primary kind of barriers that we've heard from providers and health department staff as they work through issues of stigma are really found at the systems level, and they range from electronic health record prompts not having an option for gender nonconforming individuals or transgender individuals to as one example of the sexual orientation and gender identity indicators that are so important in being able to analyze the health outcomes of LGBTQ communities. We've also heard about billing challenges around some of the STI testing, and so guidance across these different components is going to be needed in bringing together healthcare systems and public health. It's important to know and understand the framing and the priorities through which each of the sectors works. And so bringing together the continuum of prevention and care, that's kind of paramount for HIV prevention and care providers, and then in the triple aim for primary care and healthcare systems, bringing together this trifecta of priorities in terms of patient experience of care, health, the health of populations, and improving those two outcomes while containing and reducing the cost of healthcare is important. And to the extent that we can find the bridges between these two frameworks, a lot of our indicators, our outcomes, and performance measures are going to start to come together in terms of how we're able to bring in issues of health equity to this payer landscape and transformation of the healthcare system. So in addressing stigma at the systems level, we need to be deliberate in responding to the barriers that we've been identifying and addressing stigma through structural interventions, including policy but not exclusively. We need to make sure we're leveraging the healthcare landscape transformations, especially in terms of access to public and private insurance and comprehensive care, really for millions of Americans. And we also know that the impact of healthcare reform has not been equal. So low-income people of color and LGBTQ communities remain disproportionately uninsured and continue to experience access barriers related to stigma and social determinants of health. So we need to make sure that our our programs secure greater support for vulnerable populations. We need new partnerships in leveraging healthcare, including payers, which in public health, third-party payers in healthcare have not traditionally been kind of the go-to partners, but it's clear how important they're becoming. Through categorical funding, state and local HIV programs have been able to shield people living with HIV and impacted by HIV from discrimination by building a kind of separate healthcare delivery system. But these systems, as individuals move to the large general healthcare system, it's important that we work with Medicaid programs, with the insurance commissioner, and other providers and payers to make sure that the populations we care about are able to access care in a stigma-free environment. And health departments, AIDS directors have a huge role to play in that in this new set of activities and priorities that we can leverage to improve care. And here at NASTAD, through the health systems integration piece, we've had we're beginning to put together a couple of examples, and one of them is related to access to PrEP and specifically how to pay for it by leveraging partnerships between CBOs and healthcare organizations, as well as expertise from Ryan White. We're able to build those system infrastructures to make sure that they're culturally competent. Then we still have a lot of places to go, but some interesting contracting there is promising. The insurance coverage and access we've talked about, and it is really it's going to be important to make sure that key populations have access to care and care coverage that enables them to access something like PrEP, if that is what they're looking for. And then another piece that we're looking at is being able to measure and evaluate the impact of services and the health outcomes of these populations to be able to address disparities as they come up, or based on the health needs of the key populations we want to reach. So in putting all of these pieces together, we want to make sure that we are able to, that health departments, that public health programs are able to fill in gaps in coverage to make sure that that populations, that Black and Latino, gay men, and other MSM are able to access these multiple services, and that healthcare systems and public health systems across the country are not the same. So making sure that they're specific. And I'm going to leave you with this slide to think through, to kind of help us think through the framework that we need to really build a system that bridges care and prevention in HIV, but also is able to engage in this larger conversation with healthcare systems.
So with that said, we want to thank you all so much for your attendance. We definitely want to get into the question and answer section of the day, or question and answer section of the presentation. I think Carlos just sent a little bit of a text through the chat box that said if you would like to unmute your lines, press *7. To mute it back, press *6. But at this point in time, we would love to take any questions and provide any answers. If you have any questions for Jonathan, if you have any questions for us, please let us know at this time. And you can also chat them in the box, but you can press *7 to unmute, starting now. So we're not hearing any questions thus far. I'm not sure if that's because people don't have any or because they're not able to use their systems. Again, it's *7 to unmute, *6 to mute back. Moving forward, if there aren't any questions, and I will say that we do think that there's a really great opportunity for us as public health officials and public health individuals who work in public health to tack into a lot of the grassroots organizing and mobilization that's occurring within the Black Lives Matter movement. I know the Black Youth Project 100 doesn't just, it focuses on a number of different issues, and I think that there's an opportunity, Jonathan, if I'm correct, for us to work hand in hand with the efforts that you all are doing to provide a supportive role in that work. And then also, again, building strategic partnerships and working with individuals that we don't typically deal with or work with as public health workers. I think that it's important for us to realize that building of new and strategic partnerships can create new and strategic work. So I guess my question for you, Jonathan, is part of BYP 100's mission is to provide education efforts. Does BYP 100 provide trainings and educational opportunities for public health professionals?
Hey, so all of our education and advocacy efforts are directed towards the goal of organizing Black young people between the ages of 18 to 35. We do host political education sessions for the larger community, and something like that could absolutely be put together for healthcare systems. We understand that the health of our community is critically important, and it's something that has to be brought into the spotlight as people are declaring that Black Lives Matter all around the country and all around the world. Health is obviously a key part of that moment and of this movement. So we would love to work with folks around the country to make sure that health care, that the public health system is implemented into the movement.
Okay, great. Thank you so much. And I definitely want to say thank you so much for your time again. Last call, I will ask if there are any questions. If you have any questions, unmute your line, press *7. But if not, then I want to definitely thank you all so much for your time. We will be providing slides. When you close out of this platform, you should receive a survey. If you could take the survey, that would be great. And then you will receive the slides as well. I see we have one question. It's within a clinical setting, how have folks reworked program planning to include the recommendation discussed today by the Success of Black Youth Project and Queer Dreamers movement? So within a clinical setting, how have folks reworked program? So I think, and this is kind of like a health systems integration question. Do you think you can kind of provide a little more context, Edwin? Okay, sure.
I think trainings have been a big part of it. Jonathan talked about the intersectionality framework, and that's been important to get providers to understand the multiple challenges that come up. He also mentioned strengths-based counseling and frameworks, and that's also important. On a kind of structural level, in some instances, there's been specific analysis on, for example, linkage to care best practices for young MSM of color, for example, and identifying what's working and what's not specifically for a population. So if there is a specific need identified around transportation, for example, making sure that that bus cards or public transportation cards are included, or in some cases using new technology. So it's very much targeted or responding to the needs of the population that you are trying to reach or have better health outcomes. And then having a board, having some kind of graphic to show the changes that are accomplished in terms of health outcomes for that population. So including as part of your performance goals for the team, for the agency, that change in disparities.
So again, I want to say thank you all so much, and I hope that answered your question, Jennifer. Like I said, you all will be receiving slides once you click out of this platform. We also would like if you could please provide just a couple of remarks in regards to the evaluation. With that said, again, I want to thank you so much to our guest speaker, Jonathan Likes, and thank you so much for your work. And I want to thank you all so much for attending the webinar today, and we look forward to working with you in the future moving forward. Thanks so much, everyone.
Thanks, Justin.
Bye.
Bye-bye.